So hello, I come from Brazil, South America. Here you can have an image of the city of Bauru. I come from the University of São Paulo, and I practice there, and I'm also a professor at the Dental School of Bauru. And what I'd like to show you today would be something that has been my main concern along the last 15 years, which would be the design, the change in the design of the implants, especially the cone Morse implant. Actually, my main points of interest right now are short implants, everything with the cone Morse or Morse taper connection, and I do believe that we're going to have a very, very strong shift in dentistry in the next years towards the short length implants. So I have helped Neodent in Brazil to develop a very short implant with a Morse taper connection. And I really think that in the next 5 years we're going to be able to research short implants, and we're going to be able to indicate these implants in any situation. I think in the future we really should look careful when we think about these small implants, especially the 4mm diameter implant. I think that the 4mm diameter by 5mm in length will be an implant that is already tested in several instances, and I think it will be suitable for any situation in the very close future. But today I would like to talk a little bit more about some of the very critical aspects that are in everybody's worrying about these things. One of them is the distance between an implant and the tooth. It's been an issue for some years. It seems to be solved now, but I'd like to take a look at the situation under a new light. For example, think about a central lower incisor case. This is very usually a case in which you have very small space, sometimes less than 5mm, and in the past it would be absolutely unpredictable to place an implant in this situation and to have enough space to grow papilla. We have learned a lot in the last years, and we found out that we can use the 3.5mm implant if it's a cone Morse connection implant and still be able to maintain bone on top of this implant. So this was a very interesting case that from this case we started a whole line of research. So we placed this implant, we do immediate loading in maybe 100% of our cases. We really think that immediate loading is a very interesting thing in terms of bone behavior in the last years. And so you can take a look at this provisional crown. You can see that the soft tissue doesn't look so good right after the insertion of the implant. So you give it a little time, and if you can now look better at the amount of space that you have to place an implant, you will see that it's a pretty critical space. And then you can have an idea of the implant and the abutment in position. When you think about the position of this abutment right now, you can see that the prosthetic margins are below the bone level. So we used it to think in the past that it would be very difficult to have a good result having the prosthetic margin so close to the bone. But look at the behavior of the tissue 5 weeks after the placement of the implant. And as time comes, you can see it 3 months after the placement of the implant. And now take a look at the situation 1 year after the placement of the implant. Now you can analyze a little better this case, and from this case I think we're gonna take out some interesting conclusions. The implant is closer to the roots of both neighbor teeth, less than 1mm. So if you think about current literature, it would be impossible to have the preservation of bone in this area, and it would also be impossible to have papilla. But if you look at the case some time after the placement of the implant and after the maturation of the tissue, you can see a very beautiful and satisfactory result after 1 year. And we can find out that this is actually a very good situation if you think about the possibilities we had before. So that takes us to a very interesting conclusion. We learned along the last years that placing the cone Morse implant deeper in the bone would lead to better and more stable results. So if you look at this case, that was one of the first cases we did with immediate extraction and implant placement. In 1999, I extracted this tooth. We placed a very deep implant. The reason we placed it so deep at that time was a coincidence. We didn't have a longer implant available, and in order to stabilize this implant, we placed it very deep. But that was one of the first cases that showed us that cone Morse or Morse stepper implants, when placed deeper than usual, would result in a much greater amount and more stable bone. So that is, look at the situation in 2005. That means 6 years after placement of the implant. Look at the amount of bone we have, not only on top of the implant, but also maybe or probably, this is a radiograph, you cannot actually draw precise conclusions in this, but doesn't it seem like I have bone in direct contact with my prosthetic component? If you look in a greater magnification, look at this interesting situation. Even though all these things didn't have enough scientific evidence at that time, we insisted, not only our group, but a lot of people around the world insisted in trying to get more precise conclusions from this situation. So now you can look at other cases in which we placed these implants deeper than usual, and every time we did this, we found out we had more stable and a greater amount of bone around this implant, and consequently we would also have a more stable soft tissue around these implants. So we found out that that could be a very nice idea to use. This concept would be a very good idea to be used in aesthetic areas. So we started to investigate the possibilities of doing this in aesthetic areas. So that's actually the implant I helped it to develop. I had a very nice impression from Morse stepper implants, and I had the opportunities of working with the engineering group at Neodent and helping them to develop a specific design. So I very much like this design because the threads go all the way to the top. The surface treatment, which we help it to develop at my university, also goes all the way to the top of the implant. That gives us a very nice initial stability, and we have been researching also in the mechanical characteristics of these implants, and we found out this is a very interesting thesis that's just come out in Brazil, in which we found out that mechanically the top of the implant is much more resistant to any kind of strength, to any kind of load, if it's placed below the bone crest, and if somehow biologically you manage to grow bone on top of the implant. So we started to do this, and we also started to investigate the main points of interest. Like in this case, upper lateral incisors, they have always been a challenge. A lot of people still use Pontics at the area of lateral incisors. Should I do a single implant? Should I do a Pontic? Should I place implants side by side in the anterior region? So what you find out is that using a specific cervical design in the implant, and if you place it deep in the bone, you always have more and more predictable results. I'll show you later in some minutes how predictable it might be if you think about histological aspects also. So look at this thin crest. We did some expansion in this crest. We also have a lot of concern right now about the buccal volume of the bone. We not only think about osseointegration, we not only think about achieving very nice papilla, but right now we also want to know for how long are we going to be able to maintain the adequate and aesthetic color and volume of the buccal bone. So all these concerns along the last 12 or 15 years took us to the direction of different designs. So trying these designs have been very interesting. So look at the narrow spaces. Then we have the implants placed. We do, as I said, 100% of immediate loading, or at least immediate provisionalization in our cases. So one thing that I also learned when we do immediate provisional crowns is that we should also allow space for the tissue. In the beginning, when we use it, the traditional external hexagon implants, we would try to close these spaces right from the beginning, these black triangular spaces. Now we leave them open, and we found out that even though they are initially open, the tissue will come by itself because the bone will be preserved. So I was always concerned when I did these provisional crowns in the beginning. I was really worried about how would it behave along the time. But then you can find that if you just give time to the tissue, if you place your implant a little deeper, if you take care about the bone during the surgical procedures, just leave it there. Look at my mistake in this case. If you look at your right side, you can see a beautiful papilla that resulted from at least 5 to 6 weeks of doing nothing, just waiting for the tissue to come with a space open. But look at your left side. I closed it too much because I thought it was not aesthetic from the beginning, and I ended up with a caul area, just like in a natural tooth. If I had left this space a little bit wider, then I would give time for the connective tissue to mature, and then, now we know, if I wait from 5 to 6 weeks, I have mature connective tissue, then I can press it and I can shape it according to my desire, but I should wait a little bit. So look at the nice bone preservation, even though these implants, they were placed a long time ago, so we didn't have this idea of placing them deep as we do now. But look at the bone preservation, and look at the situation of the case after 6 months of insertion of the implant. So I have beautiful vertical contour. Fortunately, in this case, we didn't have to be very much concerned about the buccal aspect. But indeed, from this case, I had a very nice smile at the end. I really appreciate the smile of this girl, because now, after some years, she was a very young girl, and this is another concern about bone preservation, because we are now treating patients, very young patients with implants. So when you place an implant in a 25-year-old girl, you have to think about 50 or 60 years. So that's kind of a concern. So look at the beautiful papilla, beautiful result. So that took us towards some conclusions. The idea of using cone morse implants, if you place a narrow diameter external hexagon in an anterior area, you're going to end up with this kind of resorption. So calculating the space, calculating the precise position to place this implant is very critical. You cannot do any mistake, or this resorption will take your papilla away. But think about placing a cone morse implant flush with the bone. You have a very small amount of bone remodeling around the implant, and you preserve a lot of bone to give support to your papilla. But now think a little bit better. Think about placing this implant a little deeper, and you can now predictably have bone on top of your implant, and this bone will help to support your future papilla. So that was one of the greatest steps in the direction of changing the design of the implant. Now think about one of the greatest challenges we have now. Now we're thinking about placing side-by-side implants in the anterior region. We are trying to escape from the situation of having to use Pontics. We're using implants in very young patients. They want to have each tooth individualized. So think about placing 2 implants side by side. That has to be such a critical and precise procedure, because these implants close like this. they will induce a lot of resorption. So you really have to measure the distances between these implants. You have to be very careful to place them. Now think about changing the situation. We recently had this beautiful publications by Novaes and co-workers in the clinical oral implants research. Novaes studied Neodent cone Morse implants, and he placed them in different situations concerning the distance between these implants. So he had more deeply placed implants, and he had implants 3 millimeters apart from each other, and also less than 2 millimeters apart. And the interesting thing is that this article represented a very important shift in what we thought in the literature. Look at the histological results. After maturation of bone, he had peaks of bone preserved well beyond the top of the implants. So we had never seen that before. Even in implants that were placed closer than 2 millimeters from each other, still we preserved a lot of bone between these implants. So from this we can think that we can place two implants side by side and still be able to preserve bone and to preserve the soft tissue between these implants. The next step in what we are doing now in Brazil in our clinical research based on this animal models is to predictably place implants side by side in the anterior region and still be able to preserve bone and soft tissue. So that's probably going to be the future. And you can see, coming back a little, we have all these two situations when you place a cone Morse implant. If you place it flush with the bone, you will have a very nice bone preservation, but with a very small remodeling close to the margin of the implant. But if you are not careful to place your implant a little deeper, 1.5 to 2 millimeters deep in the bone, even though you have to sacrifice the length of your implant, we were educated to think about long implants. So we would always like to place the longest possible implant. From our knowledge, from our recent knowledge with short implants, we know now that we can use smaller implants, and it's even better if you use shorter implants, but if you place them deep in the bone, because you will cover the top of the implant with bone, and you will get a much more resistant connection of the implant to the abutment. Of course, we have to think about removing and replacing this abutment, because we know that the deeper you place your implant, the more critical it is to remove and to replace this abutment. So we have a lot of things to learn, especially when we think about the prosthodontics, because it's much more comfortable to the prosthodontist to take an impression of the head of the implant, send it to the technician. The technician chooses the abutment, and so that really accelerates the process. We are going towards an idea in which we place our abutment from the beginning, from the day of surgery, and if possible, I would like not to remove this abutment anymore. So this is something we have to think about. But we also learned a lot from my third point of interest today, which is immediate placement of implants in extraction sockets, even infected sockets. We know from a classical article by the Salama group that you can safely place implants in sockets where you had previous infection sites. We have now a safe way to do this. So we place our implants in the buccal aspect of the socket. We always take advantage of one of the roots. We always avoid to remove the septum. We also know that forces distribution in implants are not the same as teeth, so there's not a problem to have a non-axial perfect distribution. So you can easily put your implants in the best place of the alveolum. So put it to lingual, put it to the buccal. It's better to the lingual because you preserve the buccal crest. Of course, you have to think about aesthetic preservation of the volume. But look at this case. Look at this atypical shape of my provisional crown at your right side. We always do the provisional crown in a way that it can protect the borders of the socket wound. If it touches the border, we have strong reasons to think that in 24 hours we have a very good soft tissue adhesion to this provisional crown. So look at the provisional crown. It has a concave buccal aspect, which was created on purpose. I did this with a round burr, and this round concave area gets in contact with the coagulum. So actually I use my provisional crown as if it were a cork in a bottle. So I protect the whole surface of the extraction opening. I gently touch the whole peripheral area of this opening with the provisional crown, very well polish it, and then I just wait. Blood would like to come out, but it's trapped by the provisional crown. 24 hours later, I come back and I see a nice layer of glycoproteins in contact with of fibrin and glycoproteins in a intimate adherence with my provisional crown. So that avoids blood to come out. So the reason why I do this concave provisional crown is because I want the blood to occupy the space. So 6 weeks later, I have a lot of soft tissue, and then I can start pressing and changing the shape of this tissue. We always do cemented crowns. That brings us some problems. Of course, screw retained crowns are easier to deal with, but it's much easier for the prosthodontists to work in a very straightforward way with cemented crowns. But you have to be careful about trying to remove as much of the excess of cement as possible. So we always try to cement that in the standard abutment first, quickly, so as to the cement to flow out as much as it can, and then we take it back to the mouth, and then I have this very tricky technique of using the dental floss to remove the excess. You have to remember that I'm inside an open socket, so it's quite easy to leave there some excess of cement. So try to be careful with your cement. Then you can see the case 72 hours after the extraction, insertion of the implant, and making of the provisional crown. And you can see 10 days later already with the soft tissue very well maintained. Of course, let's think about years in advance. So we have been accumulating a very nice experience in this type of cases. I could say that we are conducting a very good clinical experience with now 68 consecutive cases of anterior immediately placed implants. We did a lot of experiences in the posterior area. So this is another beautiful case, tissue conditioning. Of course, we noticed that when you do that, especially when you place this implant a little more to the buccal side, you end up after 2 or 3 years with some depression in the buccal region. And of course, we can follow the now very modern philosophy brought by Dr. Garber and Dr. Salama of using some kind of a graft together with the extraction so as to retard resorption and remodeling, and so as to preserve a little more of this space. So we're trying to combine all those things. So look at the aspect of the crown. We will always have in our crowns this pontic aspect in the buccal projection. And we found out in our histology now that there's a very, very good adhesion of the tissue to this pontic area. So in the same way we deal with our regular fixed bridge pontics to condition and shape tissue, we now learn to do that with our implants too. So then you can have this very nice result after 6 months. You can look at the contour of the tissue and of the crown, and you can look at the radiograph and see that because of the Morse taper or cone-Morse connection, we have the complete filling of these socket with new fresh bone, and this bone will come all the way to the top of the implant and will provide a very nice support for the soft tissue.